Now, echocardiography in mitral stenosis, mitral valve is thickened with the commissural fusion, assessment of hemodynamic severity, mean gradient, mitral valve orifice area, pulmonary arterial pressure, these have to be assessed. Assessment of right ventricular size as well as the function is extremely important for the outcome after the intervention. Assessment of valve morphology, LA thrombus or LA appendage thrombus are very important, especially in case of mitral stenosis, which is not mentioned here. And in case very intervention has to be done, we have to do the TE to rule out the left atrial appendage thrombus. Diagnosis and assessment of concomitant valvular lesions and assessment of whether patient is asymptomatic or not is important. Now coming to the details of the echocardiography, mitral valve area can be calculated by planimetry. Mitral stenosis is classified into mild, moderate and severe according to the area. When it is less than 1 square centimeter and more than 1.5 square centimeter is considered as mild. Now Wilkins echo score is extremely important whenever you are considering the balloon dilatation, and according to this, if this echo score is less than 8, then it predicts the more favorable procedure short and intermediate outcome. Whereas in this case the echo score is not given. That is very important, because if there is a calcification, commissural calcification, and the echo score is very high, then instead of doing the intervention, we go for the surgical option. And that's how the degree of pH also is very important, and that can be done with the TR, provided the TR is not an organic one. So gradient, you all know, mild, moderate, severe, depending on the valve area and the gradient and also pressure half time, and all these the gradients, not instead of sticking to one, you have to go for the multiple parameters and take the average. And exercise gradient of more than 15 millimeters of mercury with the dobutamine test gradient of more than 18 are very significant, and they require the intervention. Now coming to the assessment, there is no single gold standard, and we have direct as well as indirect. Planimetry, continuity equation, proximal velocity surface area, that is PISA. These are all important, and indirect one are pressure half time and the Doppler gradient. And M mode, though nowadays we are not doing, it is very important for the assessment, because this is the normal M complex when you get the mitral valve, that is the anterior mitral leaflet, and W for the posterior mitral leaflet. And during the severe mitral stenosis, the EF slope is reduced. In atrial fibrillation with the fast ventricular rate, this is how the M mode looks like. Coming to the mitral valve area by planimetry, it is highly accurate and then performed with the experienced echocardiographer. Then you can see, I have seen as small as 0.2 square centimeters. That means just 2 millimeter, and doing the balloon dilatation was so difficult. And this is how mild, moderate and severe are associated. Now, what are the tips for measurement of the mitral valve orifice area? Gain setting should be just sufficient to visualize the whole contour of the mitral valve, and that is very important. Unless you adjust the gain, you will not be assessing properly. And here you can see that very good image quality is needed, and any poor image quality you will be underestimating or overestimating. Highly deformed valve due to the prior valvotomy or severe subvalvular obstruction, eccentric orifice, severe AR and atrial fibrillation, all these they hamper the assessment. So here the commissural fusion should be looked for carefully if you are sending the patient for the balloon dilatation. So that details should be given whenever the echo is given to you. The transmitral gradient can be determined by continuous wave Doppler, mitral inflow during the Dashley, derived from the transmitral velocity flow curve using the simplified Bernoulli equation. And this is how we calculate. But the magnitude of the pressure gradient depends not only on the valve obstruction, but also on the flow of the and the volume rate. And increase in the cardiac output, tachycardia, coexisting with MR, and all this can overestimate the mitral stenosis. So here they have said mitral stenosis with mild MR So that means they have not over-assessed. Probably the assessment is right. Then pressure half time is very important. Hertel's method calculates the functional orifice. It is useful because it gives information both valvar as well as the subvalvar. In the Indian subcontinent, the subvalvar fusion is very, very important in our country. For any intervention, that has to be looked for. So whenever there is MS with atrial fibrillation, we have to be careful.